Welcome to Bold Agendas, where we explore the transformative ideas and courageous leadership shaping the future of work, business, and society. Today, I'm honored to have with us Judy Persichilli, a name synonymous with leadership in the face of extraordinary challenges. Judy served as the Commissioner of Health for New Jersey during the COVID-19 pandemic, a role that placed her at the forefront of one of the most critical public health crises of our time. Before that, she led as CEO in the Catholic hospital system, bringing decades of experience in healthcare leadership to some of the most complex and high-stakes environments. In this episode, we'll dive into leadership in crisis, what it takes to make decisions under pressure, how to communicate effectively during uncertainty, and the human side of leading through adversity. Judy's insights go beyond healthcare, offering lessons for any leader in navigating a storm. So whether you're a seasoned executive, an emerging leader, or simply curious about how bold leadership shapes outcomes in moments that define history, you're in for an impactful conversation. I'm Mimi Brooks, and this is Bold Agendas. Let's get started. Judy, welcome to Bold Agendas. Thank you so much for your time and being with us today. I'm really excited to have you on.
It's a pleasure.
I think that the timing of this is really perfect for our business audience who are dealing with a lot of headwinds. And I think that some of your ideas and experience in managing a huge situation, obviously, with the COVID pandemic is going to be nothing but useful right now. So thank you so much. I think the timing of it is really perfect. So Judy, I wanted to start, if I could, in talking about leadership strategies and approaches. And maybe I could start with just how you got into this position, at the beginning, because you had obviously retired after a long and distinguished career in healthcare. And then you came back in as the Commissioner of Health to run, this whole unit for Governor Murphy. So maybe you could tell me how that happened.
Sure. Well, I actually retired 3 times. I think the third time's a charm. But I was retired for the second time, and I received a call from the governor's office from a woman who I had served on a board with. And she said, Judy, we're having some trouble up at University Hospital in Newark, which is the only public hospital in New Jersey. Would you be willing to go in and do an assessment? And I said, well, Mary, I'm retired. I'd have to think about it. I said, when can I get back to you? And she said, tomorrow. Oh. I said, tomorrow? She said, yeah, think about it for 24 hours. So I decided, I could do an assessment of a hospital. That's pretty easy work for me. So I said, sure. And I did it. And it took about 6 months, a little bit more complicated than I expected. I produced the report. Then the governor asked me if I would be the interim CEO as they searched for a new CEO, because there was absolutely no way I was interested in being another CEO of a hospital. Yeah. And I worked as CEO for 6 months, and the current commissioner, Dr. Elna Hall, had expressed interest in being CEO of the hospital. That was part of his portfolio that he had not had. And when that occurred, the governor called me. He said, would you consider being commissioner? And I thought, well, this is kind of interesting. It's a governor whose values I respect and a state that I love. I've lived in my whole life. This might be a great way to actually end my career, come to think of it. And I said, yes. And that was in August of 2019.
So Judy, when you accepted the role, we were at just the beginning of COVID. In other words, you accepted it, as a general idea. You didn't accept the role specifically to come in and manage COVID.
Oh, not at all. I accepted it as generally looking after the health of the people in New Jersey.
Oh, okay.
I thought that would be just a wonderful way to end my career as I went from bedside to administration to regional to national, and then to think that, gee, I might be able to affect the health of, the millions of people that are in New Jersey, never thinking 4 months later we would be tracking a pandemic.
And what was the commitment of time that you were initially thinking, Judy? Like when you took the commissioner role, how long did you think you'd be doing it?
Well, I lived with the myth that people in state government don't work that hard. So I thought, I'm not going to work that hard. I'm going to work 9
I could do this for a while.
9 to 5, and I'm going to have weekends off. Never a call in the middle of the night. I actually I dispelled that myth very quickly, and very quickly we were working 7 days a week.
So, Judy, what did it look like, since I didn't realize that that was your entry point? I thought your point into the role was literally at the start of COVID, so I didn't understand you actually came in before then. So what did the beginning of the pandemic look like to you all? So you didn't really have it on your radar, and then what happened?
We started tracking the situation in Wuhan, China. We started hearing, and the CDC was telling us that there was a virulent outbreak in China that appeared to be infecting thousands of individuals. So we started tracking that, I would say, towards the end of the year 2019, and then in earnest in January. So we actually called together at the department a crisis management team, the CMT we called it, and started having discussions with our key leads throughout the department about what could this be, never imagining what we were facing, but trying to be as prepared as we could be with the knowledge that we had about H1N1, flu epidemics, which turned out to be a very different circumstance.
So, Judy, in this early kind of crisis management that you were going through, were you also speaking at those times, like in the December, January timeframe, with other commissioners of health? Like, were the states starting to reach across to each other to try to share, share data, share insights, ideas, whatever?
Yeah, we definitely had group chats going on constantly. But most of it was, how are we preparing? This could be another outbreak of a virulent flu. Is anybody doing anything different? And none of us were doing anything different. Based on the data and the experience that we had, we were doing exactly what our pandemic flu plans told us to do.
So, Judy, how well did the CMT planning process hold up relative to what you were dealing with? So if you put that solution against that problem, where did it just not stack up, and where did you find some of the preparation was useful?
Well, I'll share with you a pivotal moment. It was in February. I got a call from our chief medical officer at one of our hospitals. And he said, Commissioner, I have a patient in the emergency, in my ICU in severe respiratory distress on a ventilator. And I just found out that his brother is in similar condition in a hospital in Philadelphia.
Oh.
And we are currently assessing 5 additional members of the family in our emergency room.
Oh, there you go.
Well, as it turned out, as we started, digging a little bit deeper, I said to him, get me more information. Where were all of these individuals? What were they in contact? Who were they in contact with? What are the circumstances of this, situation where it seems that they all got infected at the same time? And it turned out that they had been at a family gathering, 25 family members at an Italian Sunday dinner. And at the end of the day, of the 25, 15 were infected with coronavirus, with COVID, and 5 had expired.
So that's when you really got the huge first indicator that you had a magnitude of a situation here.
Exactly. So that was when, calling together the CMT, the crisis management team, I said, we're dealing with something different than what we've ever seen in the past. Measles being the most contagious, as you know, the most contagious viruses of all time. This could be something like measles. Where measles you walk through a room, someone with active measles could infect 18 to 20 people. This almost seemed the same way. I said, we have to prepare. And I said, I'm going to rephrase that. We have to over-prepare.
Yeah.
So looking at what was going on in China at that point, now this was late February, looking at what happened with this family, we started over-preparing. Obviously, informed the governor and the governor's office, called the CEOs of our hospitals, asked them to make plans to double their intensive care unit space. In other words, if they had a 10-bed ICU, make plans for a 20-bed. Now, my experience as a hospital administrator and, by the way, an ICU nurse, it was pretty easy for me to tell them how to do that because they were like, we don't have space. Yes, you do. You have step-down units. Your step-down unit becomes your ICU. And we went through that whole process. So if you had 50 ICU beds, have 100. So as the hospitals were preparing for that, started having regular meetings with the governor and the governor's office. And we decided to call in the Army Corps of Engineers with the assumption that our hospitals were going to be overwhelmed and we were going to need more medical space. So we called in the Army Corps of Engineers and they set up regionally 3 like MASH units, mobile hospital units, field hospitals.
Right.
Because we were at this point, we were internalizing the fact that we were in a war. We called it a war with an invisible enemy, but we had to prepare. March 4th, we had our first confirmed case. By 5 weeks later, our hospitals were inundated with 8,300 admissions of potential COVID patients in respiratory distress. That happened in the span of about 5 days.
And what would your normal admissions be, Judy, just so people see the difference between 8,300 and what would you normally be prepped for?
Maybe throughout the whole state over a weekend, you could have maybe 1,000.
Oh, wow.
So the field medical hospitals were prepared to take discharge patients. So as patients were treated and taken care of, if they could not go home or if they needed a little bit more care, the field hospitals were available to them, and we staffed them any way we could. And people from the department became suddenly field hospital operations managers.
Whatever skills they had, Judy, like whatever skills they had.
Whatever skills,
yeah.
The department, the individuals in the department, particularly the deputies that I had at the time, they were phenomenal. They took on roles you would never imagine. And we can talk about that further in the discussion. But at this point, we were in crisis. We were in crisis.
So, Judy, what were you prepared for based on your prior leadership roles? You ran hospitals, like you said, you could direct the practices in ICU. You know ICU, you know what it takes to operate that. So what were you prepared for, and what did you feel like you really had no prior experience that readied you for this?
Well, the first thing I prepared for was, and I'm sure people have heard this acronym VUCA, a VUCA
Yeah.
environment.
Yeah.
The volatility, the uncertainty, the complexity, and the worst of all things, the ambiguity of what we were dealing with really challenged all of us as leaders, particularly me as the commissioner and also the governor. Because when you're in a VUCA environment, you really, as a leader, have to really stay close to the mission of what you're trying to accomplish, because you can get so bogged down with the complexity of it, you forget how to make decisions. Remember studying, I don't know whether it was in graduate school or afterwards when we would study disaster planning as hospital administrators or CEOs, the whole concept of VUCA. And I remember when the first concept of VUCA, the volatility, really brought us to flip to vision. It was like, what do you do with volatility? Flip to vision.
Oh.
Make sure that your vision is always in front of you.
Your North
So
Star
the
is
first
always
thing-
there, right, Judy? Your North Star is always there. So when you
And
go to make a
constantly.
decision, yeah.
And say it constantly.
Okay.
The complexity of the situation, people see, you can get bogged down thinking, our goal here is to beat COVID. No. Our
Right.
vision at the department was to help all New Jerseyans live long, healthy lives and reach their highest potential. All New Jerseyans. That vision, that mission, I should say, is
Yeah.
enduring. And how we were going to get there, our vision was to get through COVID
Yeah.
and come to some type of stability. So the governor, myself, and the superintendent of the state police, Pat Callahan, we were the triumvirate. We were together every day. And we started having daily press conferences. We had over 260 press conferences.
Oh my.
Our goal was to communicate, over communicate.
Yeah.
And I ended every press conference with stay safe, stay healthy. And our mission here is to help all New Jerseyans live long, healthy lives.
Oh, you would say that, Judy. You would say that.
Constant.
You would say that constant. Oh, okay, great.
Said it at every meeting, every call we had, and there were thousands of calls, not hundreds, thousands of calls. But I wanted to make sure that people knew we would get through this. Our mission is enduring. Our vision will get us through this. And our values will tell us how. And that's just leadership. And I have to tell you, the years of experience that I had honestly prepared me for that moment. If I had not had those years of experience, the ups, the downs, the successes, the failures, I don't think I would have been as laser focused as I was.
Judy, I was going to ask you, if you had, a decision-making framework that you used as you were going through these situation this, situation that. And I feel like what you're telling me is this is kind of the framework that you use for decision-making, and people could learn it. Your leadership team could see it, right? They see you enacting it. They sort of feeling it was a reliable structure that they could make decisions by. Is that right, Judy? So,
right.
Now it becomes a bit cultural in the moment, you know what I mean? The je ne sais quoi behaviors that, what do people know, how to behave under these adverse circumstances.
What it did was ground us.
Yeah.
Because we were working, remember, then the schools were closed. Basically, we stopped all elective admissions. So all of surgical centers were closed. And remember, we had no respirators. We had no N95s. We had no protective equipment. Our own stockpile was decimated during Superstorm Sandy and not refilled. And the nation's stockpile was empty.
Oh.
So we were dealing with you know, actually just going in and taking over urgent care centers and surgical centers and taking their protective equipment so that we could distribute it throughout the state in some type of equitable fashion, particularly to local health departments and local offices of emergency management. I mean, the number of individuals and entities that had to be involved in fighting this war, so to speak, was phenomenal. It was huge. It was huge.
Fluid, Judy, was the workforce management process throughout? Because your own folks could be, obviously, they're widely exposed, getting sick themselves, right? So the resources available at any given point in time, and then trying to balance that with burnout, even if people are well, they can't work 7 days a week, 24 hours a day. How was the workforce management done?
Well, that's really interesting because when you say they can't work almost 24 hours a day, 7 days a week, the deputies and a core team and I did work 7 days a week, almost 24 hours a day. I think we would leave the office at midnight. The state was on curfew. No one else was on the streets at night when we would drive home because we were the only ones working in the office. And so there was a core group that basically did work that aggressively from our first case on March 4th to when we started to see things start to settle in a bit, or at least we thought they were, end of May through to until Memorial Day. Workforce was an issue. It was an issue for our hospitals. It was an issue for just about anyone on emergency management, local health departments. And people were constantly juggling, you take some time off, you cover. We tried to work in teams. I remember how flabbergasted we were when Governor Cuomo in New York said, well, we have Team B on, Team A is home resting. We did not have those resources in New Jersey. We did not have a Team A or a Team B or a Team C. We were moving people around as quickly as we could. And some of our biggest issues were getting people out in the field, like the surveyors. We needed to get surveyors in, particularly in long-term care, to find out what was going on, but we had to get them fit tested with respirators, and we had to make sure that they were safe going into long-term care or at hospitals to make sure that our directives were being carried out. And they were scared. They had families,
Yeah.
They were really walking into the action, so to speak. So that was, I guess, one of the most difficult, from a department's perspective, one of our most difficult challenges. We got through it, but for a period of time, till I think about mid-April, there were very few inspections going on. And there's a lot of criticism about that, but there was no way we could get people in. And the Centers of Medicare and Medicaid actually told their surveyors, of which the state has those surveyors, not to go in.
And Judy, there was no other place to get resources, right? It's not like a localized disaster, storm, whatever, where you could bring people in from other states, et cetera. So, whatever you had and that you could turn into, right, frontline workers, if you will, on the fly, was that pretty much the population of workers that you were dealing with?
Well, what was interesting is New York and New Jersey got hit first and hard. So while we needed a lot of resources, some of our sister hospitals, some from systems that I worked with in the past, they actually flew resources out to help us. I remember specifically one of the Catholic hospitals in North Jersey got a cadre of nurses from another state. So we loosened up the reciprocal licensing regulations so people could come into our state.
Oh, so that was helpful in the beginning anyways. At some point, they obviously went back, right, Judy? But you had a bit of a help in the beginning of the process. Well, that was good.
And then we also got respirators. we got respirators from California, and then when they got hit after we had calmed down, we sent them respirators,
Yeah.
ventilators, I should say. So, that type of collaboration, talk about bringing the states together in a
Yeah.
unified response, was really remarkable.
And do you think, just to hang on that collaboration for a minute, then I want to go back and finish up the decision-making framework, but did you feel that that collaboration was done kind of by those of you on the ground just reaching out to, your peers? Was it that level of grassroots collaboration and coordination, Judy? And when was it done otherwise?
Well, it was definitely a grassroots collaboration because of the contacts that everyone had built up over the years. But governors to governor, they had lots of meetings to discuss what was going on in their states and what they needed. And
they were like the first line, Judy. They were like the first line of collaboration, and then their teams could come in behind them, etc. Got it. That was good.
Yeah, it was. I do want to reference Operation Warp Speed because Vice President Pence did have regular meetings. We would meet with the governors and the commissioners of health on a regular basis.
You thought that was effective, Judy? That was helpful?
I think it kept everybody informed. The effectiveness of it was probably not as effective as the grassroots collaboration by a long shot.
But at least it created almost a horizontal communication channel among the experts like that.
Exactly right.
Yeah. So, Judy, against the decision-making process that you talked about, how much would you say was experience? How much was intuition? And then what was data? Like, what data, were you drawing on in kind of a real-time way as well to try to get, decisions, on the right side of the ledger?
Well, let's talk about experience. And I think I referenced that the experiences that I went through in my career, I don't think I could have been nearly as effective if I had not had those experiences. Because, you learn from all of the ups and downs of your career, all of the good decisions you've made, and you particularly learn from the bad decisions. And that experience really allowed me to figure out every morning when I walked into that office how I was going to show up. I was the leader. I had to be calm under unbelievable stress. I had to be confident, yet inquisitive and curious with the people around me, first and foremost, making sure they were state employees. They knew the process, making sure that I got their input and yet be confident enough at the end of the day to have to make those decisions. Had to be overwhelmingly serious in the midst of, again, the war that we were in. And yet, at 9:00 at night, when we were still in the office, had to be open to jest.
Yeah.
To find things to laugh about.
Yeah.
We laughed together, we cried together, but calm, confident, inquisitive, being able to be humorous at the right times, and build a team that was resilient.
That's what I was going to ask you is, when you look at your direct reports at the time, what were the attributes of your leadership team response that you found the most helpful and productive? You know what I mean? Like when leaders right behind you stepped up, what did you say? Thank God, like this is the kind of support that I really need.
Well, it's really interesting. I was new. I was a new leader. They had been together for a period of time. And about I joined in 2019. So they had been together for a little over a year and a half. So you're a new leader with a team that had been together, and we were in the middle of a major, major crisis. So I had to gain their trust very quickly,
Mm.
very quickly. And I remember the governor saying, when you talked about data, departments of health, the CDC, epidemiologists, they deal in data.
Mhm.
We used to call it data to action. Look at the data, what's it telling you, and then act on it. In this circumstance, the governor liked to say we were building the airplane as we were flying it. So the data was not available. So you had to use what you had real time with a large bit of education and some skill and a big dose of intuition.
A big idea of intuition, right, Judy?
A big dose of intuition. And at that same time, I had to build the trust of that team. And in the beginning, it was a little, I would say they were tentative. But as we started seeing the cases mount and then the deaths mount, I could see a turn amongst every single one of them towards the leader, basically not saying it out loud, but basically saying, what now? What
You
now?
think, Judy, that there was some tipping point in this relationship where they were like, "You're the leader. You tell us what to do." I mean, they literally looked at you at that point, knowing that they needed to look at somebody. They needed to have somebody.
Exactly. So, I can't tell you exactly when that occurred, but it was fairly quickly because these were experienced leaders in their own right.
Right.
And we were all, wide-eyed at what was going on.
At some point, it was overwhelming, right, Judy? Like, whatever that overwhelming time was, then it was like, what do you want us to do?
Right, exactly. And the response to what I wanted them to do stunned them even more.
What did you say?
I said, we're all going to take on roles that you've never had before. And they said, well, what do you mean? And I remember saying to one of them, we have to protect the most vulnerable individuals in New Jersey. Let's identify how many vulnerable groups we have.
Yeah.
They said, well, what do you mean? I said, those people that under normal circumstances we're concerned about. Under normal circumstances. We came up with 24 categories.
Segments, 24 segments of
24 segments.
Whoa.
Developmentally disabled in our group homes, of which we have thousands of them. How about migrant workers? We were entering a growing season. We were getting busloads of migrant workers in 3 weeks. How were we going to protect them? Where were they coming from? How about county jails? County jails are overwhelmed with the in and the out and the, what they do in terms of enforcement. And, some people are in our county jails for a year. Who's protecting them?
Your team built this list, Judy. Your team identified. You got to think out of the box to identify.
Totally
out of the box, right?
They came up with 24 individual vulnerable populations that had special needs and would have to be dealt with through the pandemic, not only for testing, but mostly for vaccination. Okay. Vaccines came out fairly quickly. I think we vaccinated our first nurse from University Hospital. I think it was like December 15th, 2020.
Oh, early. That's right. Yeah.
So, I asked another one to be the operations manager of the field medical stations. And she said, I'm a behavioral specialist. I said, perfect.
That's what I was looking for.
Exactly. So it was things, we actually set up a war room. Our conference room at the department was a war room. and we had posters everywhere, and people would just pop up and say, have you thought about this? And we would put it on a white sheet and start etching out the plans. And when we thought the plan was complete, that piece of paper was given to someone and said, okay, you lead it. So we built
an analog system. It was an analog system.
We built the plans together, and then we worked together to operationalize them.
Judy, how did the 24 segments affect the action plan as a result? In other words, did you use those segments to determine, how you were going to reach that population? Is that what it was? It turned into like an access idea, it turned out into an outreach idea. Is that how the segment definition was used? Yeah,
absolutely. I can remember one of our individuals who very accomplished in her own right in opioid management. And she got to county jails. I thought it was perfect. She got to county jails. She developed a very close relationship with the wardens. So it was outreach. Hi, I'm so-and-so. I'm from the Department of Health. I'm concerned about the county jails. I want to keep in close contact with you. If anyone, let me share with you some of our directives. If anyone is showing signs of respiratory distress, or cough, a fever, separate them out from the rest of the population, get them medical help, call your local hospital, or make sure you get them seen, and make sure and it just went through hundreds of directives that we put out.
Yeah.
Trying to walk people through what they needed to do to try to protect as many people as possible.
So they just knew what, literally what steps to take, just first, second, and third. Like how do I, put one foot in front of the other?
Exactly.
Very action oriented. Judy, what about workers? They're working these crazy hours, putting their own lives on the line literally every day, the worry about their families, etc. How did you keep the workers with you throughout all of this?
Well, I'm going to talk about that in two levels. I can't help but talk about it from the hospital level, because they were on the front lines during that horrible time when they had the 8,300 admissions, and the nurses and the physicians. That was one level of concern, how to keep them actively involved and able to carry out what they had to do on a day-to-day basis. So I had many, many conference calls with the CEOs, offering them my suggestions on crisis management of a workforce during a situation like this, and actually gave them standards of care in that regard that were certified and by the American Nurses Association. My past experience told me that even existed, right? Otherwise, where
would you have looked? You wouldn't even
where would I have
known? Yeah.
So I was able to give them standards of care and crisis management, and how to organize teams of care, that they had to change the everyday way of taking care of patients and actually have teams that would have a respiratory therapist, a physician, an advanced practice nurse, a registered nurse, and I said, just make rounds, go from bedside to bedside to bedside to bedside, and make sure that the needs are being met, and that you have a good download on the condition of every patient. And remember, that was when they found that turning patients on their stomachs was more effective. Have turning teams. So, what we had to say is all of the regulations that tell you ratio of nurse to patient, etc., forget about that. We're going to put in crisis standards of care, and there's different levels. And it goes from a very basic level to no ratios, teams, and just go throughout your hospital with a team and go from patient to patient to patient to patient to make sure that they were getting the care that they needed, and that their status was assessed on a regular basis.
And those were new ways of working for people, right, Judy, that are walking the walk that you're talking about. So it's one thing to kind of do the work design, the redesign
Right.
of work, right? And then it's another thing to get these teams who weren't teams before like this, right? These teams, actually going about their responsibilities every day. So the change in work practice behaviors was a pretty big idea, right?
It was huge.
Yeah.
It was as big as the over preparedness when I said to the CEOs, increase your ICU capacity by 100%. By 100%. 10 to 20, 20 to 40. They said, I have to they listened. They actively listened. And I think out of respect, because they knew I came from the hospital side, they did it.
Yeah.
And I can't say enough
Yeah.
about how the hospitals responded. And then I had the Department of Health individuals, that workforce. And, the biggest struggle was with the nurse surveyors, trying to get them the protective equipment so that they could do their work. And it was work that they wanted to do. And then it was the interaction with local public health. Local public health had been decimated, not only in New Jersey, but nationally.
Prior to the pandemic.
Workforces were decreased, grants were decreased. And, in communities, local public health works very closely to the Office of Emergency Management. And the Office of Emergency Management, under the superintendent of the state police, Pat Callahan, became great partners to me and to the Department of Health and to local public health.
Feet on the street, right, Judy? That's like a feet on the street analogy.
Oh, yeah, absolutely. I mean, I could get into so much detail about contact tracing and how local public health is responsible for that. And in most epidemics, that's how you track the disease and know how to protect people. At one point, we had to throw that all out the window. Prior experience with flu did not help us with COVID. It was a different situation. Flu being mostly a droplet infection, wear a mask, stay 6 feet away. Remember that? Stay 6 feet away from people. I think at the end of the day, there's agreement that COVID is aerosolized. Smaller virus, able to, when you sneeze, go out a number of feet, and highly communicable. So that's why we had to close down the state.
To help, right, in terms of the prior experience of dealing with that, but it also sent you down some wrong paths, Judy. Like you chased ideas that turned out not to be relevant. So some effort, time, energy, whatever it was wasted while we figured out the lessons learned about what in fact was really, creating momentum here.
Yeah, once we internalized that we were dealing with a novel virus, as I told the department on a regular basis, this is a novel virus, never before seen in humans, and it requires novel responses.
Yeah. Judy, what didn't work, especially from a communications perspective, or even from your early prep? You put a lot of eggs in a certain basket of ideas, and you found that as you went forward, its value diminished really quickly. So, what were you thinking might work? And then if you had to do it again, you'd say, that really was not the right approach.
Well, there are a couple of things that didn't work, and the state bureaucracy through Treasury to get things approved was a little bit lengthier than we would like, and it took us a while to deal with Treasury and be able to move things more quickly, whether it was purchasing masks or a number of things. What didn't work, and I think is one of our biggest learnings in the Department of Health, everything we do is by directive, so even if a law is passed or there's an executive order from the governor, that then, and it has to do with health, it comes to the Department of Health, and we write a directive. This is what it is. This is how you carry it out. These are basically the regulations, and this is how you carry it out. I would bet we did 300 directives, maybe even more. Every day, something new was coming out, and we wrote a directive for it. And it had to go through legal. I mean, to make sure that things were, okay. If I had to say our biggest mistake is we didn't take the time or have the time to help those who got the directive feel comfortable enough saying, I don't know how to carry this out. I'll give you an example. And it was our worst situation. It was what was going on in our nursing homes. And we put out a directive that said you have to accept patients that you have sent to the hospital. You have to accept them back. Our concept was that was their home. I mean, where were they going to go? They were cleared. They were improved. They were cleared of the virus. They were safer going back to their home. But we had a directive that said, make sure you can cohort, meaning you separate out your patients, those returning that have been treated and survived, and those that are still in the nursing home and perhaps could be contagious, so maybe fine, but separate, cohort.
Yeah.
If you don't have the staff, don't let us know, and we opened up a hotline for that. Let us know, so that we don't want to return anyone to an unsafe surrounding. They were like two of the biggest, but make sure you let us know. They couldn't operationalize the cohorting. The physical plants perhaps didn't allow them to do so, or the operational management of nursing homes in many respects did not have clinical knowledge or experience. So within a week after that directive went out, we called a couple of large providers of nursing homes, and we were able to open up shuttered nursing homes as an alternative space for patients. And I think at the end of the day, about 1,500 to 2,000 patients were sent to other than what I call their homes, where they had lived maybe for years, because the nursing home could not accommodate them.
So
and that was a difficult journey.
Yeah, that's hard. I remember, some of the issues at the time. And so, Judy, that's like you identified the vulnerable populations. You must have identified these folks. Of course, they're obviously ones, right?
Of course.
And but in some of these vulnerable situations, there was like organizational capabilities that wrapped around them in some way or another, and the readiness or competency or skill, whatever, of that system, it was not necessarily as apparent.
Exactly.
When decisions were made. Yeah.
Exactly.
Yeah, I get it.
So that I would say of everything, that was the most difficult, and disappointing. But it certainly taught us a lot about the resiliency or lack thereof of long-term care. So one of the things we did get into the budget in New Jersey is within the department is an Office of Long-Term Care Resiliency.
Oh,
and the whole goal of that office is before long-term care gets into trouble, that we have a cadre of experts that will go in and help the administrators improve the situations that they're in.
That'll be a good center of excellence in the future, right? In terms of, dealing with that. They'll know what's going on the ground when it might be difficult to see it, if you're.
And it's separated out from enforcement, because we have a Department of Health has a regulatory and enforcement arm, and we purposely separated it out from enforcement so that nursing home operators would not feel intimidated to call in the experts to say, I need help.
Yeah, that goes to the, what people felt comfortable in saying in the middle of the moment, right?
Yeah.
Yeah, I'm with you. Judy, just real quick on this one, I'm just wondering whether there was any real headwinds that created operational, barriers or headwinds to you, coming from any political side. Obviously, I'm not trying to get you to air dirty laundry. I'm just trying to understand it as a stakeholder group. Anything coming in from the political side or any economic considerations, that ended up being things that you really had to, factor in while we're trying to figure out how we run the human services side of things.
Yes, and yes. So we had all of those. We had all of those headwinds. And I can remember days being in the war room and the criticisms that we were getting from certain, political aspects of what was going on in my deputies having tears in their eyes. They were working so hard. And I said, okay, everybody, remember when you were in grammar school and one of our favorite poems was Kipling's If you can keep your head when all about you are losing theirs and blaming it on you, and if you can trust yourself when all men doubt you, but make allowance for their doubting too. I said, remember those opening lines. This is the situation we're in. Keep your head about you. We're doing the right thing. We're doing the best we can. And if you can keep your head, we'll be fine.
Yeah. Well, this is like the thread that ran through it, right, Judy, in terms of we were going to do this by our values. We weren't going to do it necessarily by our playbook as much as we were going to do it by our values, right?
We said all the time, remember, mission is enduring. It's our purpose for being here. Vision is how we're going to get there. And values can never be compromised. Mission is enduring. Vision sets your direction. Values tells you how to do it. And we repeated that constantly.
It's helpful. It's a helpful reminder. Judy, I was going to ask you if you had any advice for, leaders, people that could be, in situations where they're running agendas, big, difficult agendas, and they're trying to balance, this idea of being innovative and leaning in, perhaps without the playbook, probably without the playbook in some way or another. And you can see a million examples of why that could be happening today in terms of, what business leaders might find themselves in. And yet, all constituents expect them to manage risk and to manage it appropriately relative to the boldness of their actions. So what would you say, Judy? Like, how do you advise leaders? Is it, this value stack that you just said? Is it anything else that your experience kind of taught you?
Well, the first thing I say to emerging leaders is leaders are not chosen to maintain the status quo. Anybody can do that.
Yeah.
You're paid to be innovative, to change, to move the mission as far and as wide as you can. And the mission calls for that. That's your purpose. And you're going to take some risks, calculated risks. Don't be crazy.
Yeah.
Calculated risks. And you want to be innovative. There's no doubt about it. But understand that your job is to initiate change. And everything you ever learned about building teams around change have to come into focus. And the one thing, when you show up every day is to be authentic. Because if you're not an authentic leader, if you are in that for something other than the mission of the organization, your people won't follow you. They will know that.
People smell that, don't they?
They smell that a mile away.
They really do. They really do. I was going to ask you that before, Judy. It just seems to me that besides this experience piece that we were talking about, you've got to show up authentically, especially in the time period that you had to build trust, the team with people. And, there's just no getting away with it. There's no getting away with it otherwise. People might not know what to do instead, but they know it when they see it.
Oh, they know when they see it. I have had a couple of mantras throughout my career, and particularly during this situation. First and foremost, I said to the team, you can disagree, but don't be disagreeable.
Yeah.
You can disagree, but don't be disagreeable. We have no time for that. It doesn't serve any purpose. Take your work very serious. Don't take yourself too seriously. We're fortunate to be in these positions, much more fortunate than a lot of other people.
Yeah.
But don't take yourself too seriously. It's
Yeah.
not about you.
Yeah.
Again, it's always, everything goes back to the mission.
Exactly. And we'll leave it with the last one, which is and don't be crazy.
Please don't be crazy.
Please don't be crazy. There's the recipe, Judy. There's the recipe. Judy, I can't tell you how thrilled and privileged I feel in having had you here. And I'm just certain that there's so many lessons in this. Ken is taking notes. You don't even need to take notes. I'm not sure what he's going to do with those notes. It was really generous of you. Thank you so much. And it's great to see you. And I'm glad to see you at all, but hopefully I'll see you in some other forum in my podcast in the near future. And I hope you get out of the cold weather and get down to the beach sometime soon.
I hope to see you soon, and thanks so much. This was a pleasure. It's not often that I get to rehash what we all went through, but I do have to tell you the foxhole, which is exactly what we call ourselves. The foxhole, we get together for dinner once every 4 months.
Good for you.
And
Nice.
it's just like my dad did with his World War II buddies.
Isn't
And
that
I
nice?
remember as a little kid, we called them uncle. We didn't understand. We weren't related to, they were uncles. And they got together, and I can remember them being in another room and with raucous laughter. And that's exactly what we do.
That's really
exactly
nice.
what we do.
Well, I think just to comment on what you're saying, I mean, obviously it creates a tremendous bond, that probably is a lifetime bond. But, your comment about, you don't do many of these. I think you should be turning these down on a weekly basis, because I do. You should be leave me alone, talk to my agent, because these lessons in leadership are invaluable. And I feel very strongly that, if we don't have an apprentice, culture in terms of leadership development, we're really missing a big opportunity. So we'll try to get this out to folks that, should be on your doorstep already anyway.
I hope not.
But I don't want to encourage people to do that.
You can edit that. I hope not.
Judy, so good to see you. I hope to see you soon. You take care. Bye now.